യൂട്യൂബിൽ ലൈവാണ്.
Shall I start? A very happy 2021 to all of you, and let us hope to win against the pandemic this year. Thank you all for joining in today for the second webinar in the IAC Dual 50 series on Shall I start? Yeah. A very happy 2021 to all of you, and let us hope to win against the pandemic this year. Thank you all for joining in today's for the second webinar in the IAC Dual 50 series on the best of Journal of Cytology. As they say, child is the father of man. What we sow today, we reap tomorrow. And that is why the Executive Committee of the Indian Academy of Cytology consciously has chosen to embark on this exciting session to encourage our younger generation who are actively pursuing cutting edge research and publishing it in our own journal, the Journal of Cytology, in the true spirit of Atmanirbhar Bharat. The three presenters today, Dr. Veena from RCC Trivandrum, Dr. Vani Gupta and Dr. Soumya Shukla from RML Institute, Lucknow, are the top three papers which were published in the Journal of Cytology in 2019 and were considered for the Dr. Panna Chowdhury Award, which was instituted by Dr. Monisha Chowdhury a few years ago in the memory of her late husband, Dr. Panna Chowdhury, a very eminent pediatrician. To chair this session, and I hope that this session will encourage all the youngsters who are listening to us today, which will inspire them to do good research and also publish it in our own journal. And to chair this session today, we have with us two very eminent cytopathologists, Dr. Prabal Dev, Dr. Colonel Prabal Dev, who started his career in AFMC. He retired after 28 years of service to the country in the army and retired as senior advisor and professor and head of pathology hospital, Kolkata. He followed it up with a stint in ISRL Diagnostics, Mumbai, and is currently the COO and chief histopathologist, NM Medical, Mumbai. He is one of the authors of the Boyd's Textbook of Pathology. He took over as editor-in-chief of the Journal of Cytology since January 2016, and under his able command, he and his team have been able to take the Journal of Cytology to greater heights, and currently it has a very good impact factor of 0.6. I thank Dr. Colonel Dev for having accepted our invitation to chair this session, and he indeed is the best person for this session since we are talking of the best of Journal of Cytology. Co-chairing with him is Dr. Deepali Jain, who is an additional professor in the Department of Pathology, the All India Institute of Medical Sciences, New Delhi. She has made a mark in the international scene in the area of thoracic pathology and cytopathology. She has several review articles to her credit, publications, grants, and has recently authored a book, Atlas of Thymic Pathology. Her thrust area of research is lung cancer, and who better than her to chair and co-chair and moderate this session for us. Thank you so much, Deepali. All the papers today that are going to be presented are indeed in the field of lung cancer. And with these introductory remarks, it's over to our chairpersons, Dr. Prabal Dev and Dr. Deepali, to conduct this session. Over to Dr. Colonel Prabal Dev.
Good evening. Wishing everyone a very good evening and Happy New Year from the editorial team of Journal of Cytology. At the very outset, I would like to thank Brigadier Nijavan, President, ISE, and Professor Radhika Srinivasan, Secretary, Indian Academy of Cytologists, for inviting me to chair a novel webinar, that is Dr. Panna Chowdhury Award Paper Session, to felicitate the 3 best research articles published in Journal of Cytology for the period 2019-20. Journal of Cytology has traversed a long distance over the past 1 decade and today has established a niche for itself in the domain of cytopathology. This fact is not only supported by the impressive impact factor of the journal, but also the high quality of original articles that are being submitted and published in this journal of ours. Even the ongoing pandemic could not deter the spirit of the contributors, and JOC has received a phenomenal 255 submissions from national and international institutes of repute during this year, despite the fact that publications are now restricted to original articles only. I place on record my sincere gratitude to all the authors, their guides, our esteemed reviewers, and all members of this prestigious academy, and especially my editorial team, Colonel Rohit Tiwari and Colonel Ajay Baranwal, for the continued support in this journey. The exemplary quality of research articles is aptly exemplified by the 3 award papers. Interestingly, all 3 pertain to pulmonary cytopathology and highlights need for molecular workup for optimal evaluation of pulmonary tumors. Prior to embarking with the main award papers, it is my proud privilege to invite my co-chairperson, Dr. Deepali, who is an additional professor in Department of Pathology, AIIMS, New Delhi. Dr. Deepali Jain has done phenomenal work in this field, and I would request her to kindly share her experiences and present a brief overview of the current status of pulmonary cytopathology workup. Over to Dr. Deepali, please.
Thank you, sir, and good evening, everyone. New Year greetings to one and all. At the outset, I would like to thank Professor Radhika Srinivasan, Secretary, Indian Academy of Cytologists, for kind introduction and an invitation to co-chair this very exciting session on Best of Journal of Cytology with Dr. Prabal Dev, who is Editor-in-Chief of JOC. Thank you, Dr. Dev. So before we hear these 3 outstanding papers, I would quickly give an overview of current status of lung cancer testing in cytology specimens. So in these 10 to 12 minutes, I will show you 4 cases and pose 4 or 5 questions related to these cases and discuss their answers in terms of type of tests, type of specimens, and type of methods which are used in lung cancer testing. So begin with the case 1, who is a male smoker. EBUS FNA has been done from an enlarged hilar lymph node. And as we can see here that these are direct smears, Papa-Nicolau stained smears, and they show features of adenocarcinoma. These tumor fragments were scraped manually by a surgical blade to get pure tumor population of the cells to avoid false negative mutation results from these background non-neoplastic lymphocytes. So this tumor sample subjected to real-time PCR method, and this case was positive for EGFR exon 19 deletion. So here are 2 questions related to this case. The first one is direct smear scrape. Is it appropriate specimen to test for EGFR mutation? And the other question is, what are the other methods for EGFR mutation detection in addition to real-time PCR? So as this case was positive for DEL19 EGFR mutation, a patient was put on EGFR inhibitors. And as we can see that in response, this patient responded, and this can be seen in post-therapy imaging pictures, and his progression-free survival was 14 plus months. Coming to case 2, who is a 50-year-old woman, never smoker, pleural effusion was positive for these tumor cells, which are in the form of 3-dimensional big clusters, and they were positive for TTF1 immunostain compatible with primary pulmonary origin. This case was negative for EGFR mutation analysis, whereas ALK IHC was positive. As we can see here on the cell block of pleural effusion specimen, the ALK IHC was diffuse, strong in intensity, and granular positive. Further to that, this case was subjected to combined ALK cross break apart FISH, and it did show ALK gene rearrangement in the form of break apart in the ALK gene, whereas the ROS1 gene was intact. So the question here is that, is FISH necessary to perform in a case which is clear-cut IHC positive? So as this was positive for ALK rearrangement, this case was also put on ALK inhibitors and responded very well to therapy, as can be seen in post-therapy imaging. Coming to case 3, who is a 68-year-old man, never smoker, CT-guided FNA was done from the lung mass, and it did show fragments of tumor which are non-small cell in histology and compatible with adenocarcinoma. Similarly, on the cell block also the tumor cells were seen. So this case was negative for EGFR mutation and ALK rearrangement, but on cell block, ROS1 IHC was diffuse and strong positive. So the question number 3 here is that based on this positivity on ROS1, patient should be treated with ROS1 inhibitors or not. Case 4 has 2 patients. The first patient is this case of squamous cell carcinoma. And this is a picture of PDL1 IHC, SP263 clone, and where we can see that almost all tumor cells show strong complete membranous staining. So here we can say that tumor proportion score is 100%. The other patient in this case is the case of non-squamous carcinoma, non-small cell lung cancer, non-squamous histology, and here the tumor proportion score is less than 50%. So the question here is that PDL1 IHC score, does it have any role in deciding treatment regimen for the patient? So before we answer these questions, I'll just give an overview of the key things in diagnosis of lung cancer. And the key factor in lung cancer is to differentiate non-small cell cancer from small cell carcinoma on morphology, on cytology, or on histology. And if it is non-small cell cancer, whether it's squamous or it is non-squamous histology. So in a clear-cut case like these two, it is very easy to find out the lineage determination. But if a case is morphologically undifferentiated, then the question here is what are the best first markers to classify accurately non-small cell lung cancer into adeno or squamous cell carcinoma? So the answer is TTF1 and P40. This combination has the best sensitivity and specificity. The next question in diagnosis is that what portion of cytology samples they are best for immunostaining or immunohistochemistry? Are they cell blocks or air-dried or ethanol fixed smears? So answer here is that all cytology preparations, not just cell blocks, they are all, air-dried or alcohol fixed, especially alcohol fixed smears. They are very good for doing immunocytochemistry. So for example, in this case, this was quite undifferentiated tumor, but TTF was blowing up and kind of saying that this is an adenocarcinoma. Similarly, in a case of squamous cell carcinoma, P40 can be done on cytology smears per se, and they are positive. So coming to the predictive biomarkers, NCCN guidelines 2018, they say that all advanced non-squamous carcinomas, they should be, or the must test biomarkers in these tumors are EGFR, ALK, ROS1, BRAF, and PDL1. And PDL1, in addition to non-squamous, it is also useful in squamous as well as small cell lung cancer. And so these are must test biomarkers, and these 5 are should test biomarker. That means that if you are doing a multiplexing genetic analysis, you should include these 5 genes as well in your testing panel. So for the genetic, for examination of these genetic aberrations, multiple testing tools we have to use in the form of either immunohistochemistry, fluorescence in situ hybridization, or mutation analysis in the form of PCR-based methods or sequencing. So coming to our questions, the first question, direct smear scrape is appropriate or not? The answer here lies in guidelines which are published in 2018, where it has been clearly stated that you can use either cell block or cytology preparations. Unlike earlier guidelines, which were proposed in 2013, where they have emphasized on formalin-fixed cell block specimens, but here all cytology preparations are good enough for detection of EGFR mutation. And coming to the other methods of EGFR mutation detection, so although there is no consensus about the best assay for EGFR detection, but the ideal assay should be sensitive and specific for EGFR mutation detection. And so therefore they have a kind of removed Sanger sequencing from the guidelines because it has low sensitivity, and they have switched to multiplexing hotspot mutation test, very sensitive tests like PCR based or sequencing based tests. So this is answer number 1. And coming to IHC in fish, role of IHC in fish in EGFR mutation detection, fish is obviously not recommended for detection of EGFR mutation. And they have, in 2018, they have even removed EGFR mutation specific IHC for selection of patients for EGFR tyrosine kinase inhibitors. However, having said that, these IHCs, which are mutation specific for two commonest mutations, exon 19 deletion and L858R mutation, they are useful in a setting where we have just a paucicellular cytology preparations and where we don't have material for mutation testing. So therefore, rather than doing nothing for patient, if we can use these antibodies as a screening mode, when they are positive, they can benefit patient. So this is the role of these two antibodies. Coming to the current state of practice ELK testing. So if you have immunohistochemistry, which is this much strong, which we have seen in our case too, by companion diagnostic assay, that is ELK D5F3 assay, or if you're doing your lab developed test and it is a clear-cut 3+ positive, then you don't have to do FISH in those cases for selection of patients for putting them on ALK inhibitors, whereas FISH is only warranted in cases where your IHC is equivocal or negative, where clinical suspicion of ALK rearrangement is there in patients. So in those cases, only FISH is required. So answer number 2 is that in a case where IHC is that strong and clear positive, there is no recommendation for doing FISH. IHC can work as a standalone standalone method for putting patients on ALK inhibitors. Coming to the ROS1, as we know that ROS1 is a must-test biomarker, and unlike ALK IHC, ROS1 IHC may be used as a screening test in lung adenocarcinoma patients, whereas positive ROS1 IHC results, they should be confirmed by a molecular or cytogenetic method because it's a sensitive method, but it is not specific. So as we have seen in our case, the answer here is no, that based on ROS1 positivity, you cannot put a patient on ROS1 inhibitors. You have to confirm it by either FISH or real-time PCR-based method. And in this case, ROS1, again, the same combination ALK-ROS break-apart FISH was performed, and this case was positive for ROS rearrangement. ALK gene was intact. So this patient is now eligible for ROS1 inhibitors. Coming to PDL1, updated NCCN guidelines 2019, PDL1 should be employed as a biomarker to direct initial therapy in patients who are molecularly wild type, meaning to say if they are EGFR, ALK, and ROS1 negative, they should be tested for PDL1 for first-line immunotherapy. So in clinical practice, if you have high PDL1, that is more than 50%, patients should get immunotherapy alone. And if they have lower PDL1 expression, for example, in our case, less than 50%, then they should be given combination IO plus chemotherapy. And if clinicians want to start these immunotherapy in second or later line of treatment, then even more than 1% PDL1 expression is good enough to start immunotherapy. So whenever you have driver mutations, targeted therapy should be given, not immunotherapy. But if they are molecularly wild type or if they are squamous cell cancers, like first case where we have 100% TPS and squamous cell carcinoma, these patients should be given immunotherapy alone. And if the tumor proportion score is less than 50%, then combination chemotherapy plus IOs should be given. Now, the second question here, we know that diagnostic IHC in cytology preparations is good, but how about predictive immunohistochemical testing in cytology specimens? So predictive biomarkers are PDL1, ALK, and ROS1 IHC. For that, cell blocks are currently the recommended preparations. And if you are using non-cell block preparations or cytology smears for these three IHCs, rigorous protocol optimization, validation, and quality control is definitely required to practice these tests in clinical care. So PD-L1 ICC or immunocytochemistry, unlike ALK and ROS1, here we need 100 viable tumor cells because first of all, it is a heterogeneous stain. And second, it comes positive in macrophages and immune cells. So it is very important if you have, you should have 100 viable tumor cells. And for scoring, we don't care about the staining intensity, but the membranous staining, complete or partial, should be there to score tumor cells. Since alcohol hampers PD-L1 staining, the current recommended or preferred thing is that formalin-fixed cell blocks you should use if you are using cytology preparations. Formalin-fixed cell blocks are an ideal specimens for doing PD-L1 immunocytochemistry. So after that, back to our case 1, where we have seen that patient responded to first-line EGFR TKI, but then patient progressed clinically and radiologically after 14 or so months. So this is because of secondary resistance to EGFR TKI. So now what is next for this patient? For these type of patients, the recommendation is to use cell-free plasma to test the most common cause of EGFR TKI resistance, that is EGFR T790M mutation, which is the most common cause. And for that, you can use liquid biopsies from plasma. If they are positive, then patients can be benefited by advanced generation TKIs. If they are negative, in that case, tissue biopsy is required to test for them. So a liquid biopsy is not just restricted to blood plasma. You can have cell-free DNA from all the cytology preparations. You can have them from the supernatant. You can extract out cell-free DNA and test for EGFR mutation from these cytology specimens. So in this case, in this particular case, blood plasma was used for cell-free DNA extraction post to ddPCR, and this case was positive for EGFR T790M mutation. Patient responded to advanced generation tyrosine kinase inhibitors and currently on follow-up. So this was kind of overview of diagnostic and predictive markers in lung cancer testing. It's a rapidly evolving field, lung cancer. In understanding concepts, rapid technology development can be seen. NGS people are using, liquid biopsies are following. But for us as a pathologist, IHC remains is a very strong, valuable marker. And at last, morphology will definitely survive. With this background, I'll invite our first speaker, Dr. Veena, for her presentation.
Good evening, ma'am. Good evening.
Good evening, Dr. Veena. Dr. Veena is a senior cytotechnologist working in Division of Pathology, RCC, Trivandrum, Kerala, and she will present her work now. Over to you, Dr. Veena.
Thank you, ma'am. Thank you, ma'am. Good evening, everybody. First of all, I would like to thank the Secretary and Chairpersons of IAC for selecting me for this presentation. This work was done as a part of my PhD thesis under the guidance of Dr. K. Sujathan, Division of Cancer Research, Regional Cancer Center, Trivandrum. And let me go to the presentation. Slide, please. This article was entitled Immunocytochemistry on Sputum Samples Predicts Prognosis of Lung Cancer. This was published in January 2019 issue of Journal of Cytology under the guidance. This work was done under the guidance of Dr. K. Sujathan. As you know, lung cancer is one of the leading cause of cancer-related mortality, and non-small cell lung carcinoma accounts for about 75 to 85% of lung cancer. And despite recent advances in diagnosis and intensive therapeutic efforts, there is no real improvement in the survival has been achieved. And the prognosis found to vary even in patients within the same stage. So there is a need for predictive markers so that adjuvant therapy can be given to reduce chances of recurrence and the survival rate. As it is a heterogeneous and complex disease, multiple markers may be more helpful than employing a single marker. So we have selected 4 markers. Even though there are different methods for detection of lung cancer, sputum cytology is one of the simple, non-invasive diagnostic method for lung cancer. And its usefulness of sputum for prognosis prediction is yet to be explored. So Validation of markers in sputum for prognosis prediction is useful for employing selective therapy. So the main objective of our study was to evaluate a reliable panel of immunocytochemical markers for their significance to predict survival in sputum samples. So we have selected 4 markers: P60, P53, EGFR, and Galectin-3 based on their role in cell cycle regulation, proliferation, apoptosis, etc. Now coming to the role of P16 and P53. P53 is a tumor suppressor gene controlling G1 checkpoint and cell cycle regulation. It has anti-proliferative and anti-transforming activity. It also regulates cell arrest in G1 phase and apoptosis. The P16 gene product of CDKN2A P16-INK4A binds to CDK4 that in turn inhibits the formation of CDK4 cyclin D complexes that leads to the inhibition of cell cycle dependent phosphorylation of retinoblastoma protein. And the loss of cell cycle regulatory function of P53 has a synergistic effect with the altered P16 protein status. Now we can go to the role of EGFR and Galectin-3. Epidermal growth factor receptor tyrosine kinase activates many pathways like RAS, RAF, and MAC kinase pathways that may lead to cell proliferation and apoptosis. Sorry. Improper activation of EGFR tyrosine kinase results in increased malignant cell survival, proliferation, invasion, and metastasis. And coming to Galectin-3, it is a multifunctional protein that is found intracellularly and extracellularly. And its role in regulation of its role is in regulation of cell growth, cell adhesion, cell proliferation, angiogenesis, and apoptosis. And intracellular Galectin-3 inhibits apoptosis. Now coming to the methodology, the samples for the study were selected from a cohort of 3,185 patients referred from Sanatorium for Chest Disease Hospital and Medical College Hospital, Trivandrum, with a history of COPD or clinical symptoms suspicious of malignancy. From this, we have selected 90 patients based on the adequacy of sputum samples and the matched tissue samples and clinical data. And among these, there were 25 adenocarcinoma, 33 squamous cell carcinoma, 25 non-small cell lung cancer, and 9 small cell lung cancer. And sputum samples were collected for 5 consecutive days, and these were homogenized using cytorich red solution obtained from TriPath Imaging Company. And along with this, the clinical data were also collected. The samples were a vortex, and then it is centrifuged 800 G for 10 minutes, and the sediment obtained was re-suspended in buffer and again centrifuged, and the sediment is first a monolayer was prepared and the remaining samples were used for cell block preparation. Then the cell block, 5 micron sections were obtained from the cell block, and the matched tissue samples, these were subjected to immunocytochemical examination using DAB as chromogen and counter-stained with the hematoxylin. We used the standard avidin biotin technique for IHC. And his score was calculated as the product of intensity and distribution, and the S-score above 20 was taken as positive. Then it is correlated with the clinico-pathological parameters. And for statistical analysis, we have used SPSS 11 software, and the expressions of different markers were correlated with the clinico-pathological features, and the significance were assessed using chi-square analysis. Then the prognosis was assessed using Kaplan-Meier analysis and compared with the log rank test. This study was approved by Institutional Review Board and the Human Ethical Committee. Now coming to the results, we can see the P16 expression pattern in adenocarcinoma. First one is A is cell block. Here we can see the dense expression in the nucleus of adenocarcinoma cells. The matched tissue samples, there are dense expression also. Some of the cells show diffuse expression. The lower one, C, that is squamous cell carcinoma in sputum samples. Then D sample shows its matched tissue sample. Then This one, P53 expression, adenocarcinoma sputum, dense expression can be seen on the right side, that is matched tissue sample, and the lower one, G, that is in squamous cell carcinoma sputum sample, and that is matched tissue sample. Dense expression can be seen. Next, please. Then EGFR expression, it is mainly in the cytoplasm and membrane, we can see. Then adenocarcinoma and the matched tissue sample. Squamous cell carcinoma also we can see. Then here matched tissue sample. In the tissue sample, there is slight staining on the cytoplasm also can be seen. And the nucleus is, the membrane also some dark stain. EGFR positive expression had significant association with the metastasis and histological type of tumor. Now coming to the galectin-3 expression, galectin-3 is usually found in the nucleus and in the cytoplasm, as it is found extracellularly and intracellularly. And we can see it in the adenocarcinoma in the sputum samples and the matched tissue sample. And the lower one, it is seen on the sputum samples and tissue sample. And galectin-3 nuclear expression had significant difference with the P53 and P16 expression status. This is a box plot showing X score of different proteins in different histological type of lung cancer. First one is P16 expression, and then GAL3 cytoplasm, GAL3 nucleus, and the upper right side, that is P53 expression, then EGFR. Here we can see the Western blot analysis. We have done Western blot analysis to test that sensitivity of antibodies. We can see the dense expression of P16, galectin-3, P53, and EGFR on the right side for tumor cells, and the normal, there is no bands can be seen. Now coming to the survival analysis by Kaplan-Meier method, we have done, first of all, we have done overall survival by for expression patterns of all tumors. We can see that P16 negative and positive tumors found that overall survival, for P16 negative tumors, only 35% of cells have survived. For 1 year survival was 35%. And for positive tumors, it was found to be 42%. And for here, galectin-3, there is a slight error here. It is P53 was written, sorry for the error. And here also, galectin-3 has a cytoplasmic expression pattern. Positive tumors at 39.4% have survived. And for P53, 1 year survival for positive tumors are found to be 38.6%. For EGFR, the overall survival was found to be for positive tumors 9.5%. But overall survival, we found no significant values for all the markers. So we next we went for univariate analysis for all potential prognostic markers. Then we found that only composite stage was found to be significant. Please. Then we have performed the survival analysis by stage with reference to the expression pattern of different proteins using Kaplan-Meier method. Here we have found that the survival by stage for P16 positive tumors have, for stage 1 tumors, it is found to be 60%, and for stage 4, 25%. 2 year survival was only 47.6%. And for P53 positive tumors, 2 year survival for stage 2 tumors of 37%, and stage 3 tumors were 5.3% only. For P53 positive tumors, 2 year survival was found to be stage 3 tumors were found to be 20%. And galectin-3 cytoplasmic positive tumors, 2 year survival was noticed in stage 1 and 3, 38.1% and 5.2% respectively. For GAL3 cytoplasm negative tumors, stage 1 and stage 2 tumors was about 25% and 13% respectively. EGFR negative cases, 1 year survival was found in only 5.7%. So we have found significant values for overall survival for all positive tumors and GAL3 cytoplasm negative tumors. Next, please. The results continued, and we found that negative P16 expression had a shorter survival period, and P16 expression was more frequent in squamous cell carcinoma. And survival of P53 positive cases was comparatively lower, and mutated P53 stage 3 tumors have worse survival benefit than stage 1st and 2nd. This was also supported by a report by Honchak et al. And the survival probability of galectin-3 cytoplasmic and nuclear negative tumors was higher. There is a report by Volant et al. Also having the similar results. EGFR positive tumors had a longer period of survival than negative tumors and had significant association with the metastasis. Then the tissue and cell block or monolayer preparations had no significant difference on survival analysis. Now coming to the conclusion, an accumulation of mutated P53, overexpression of galectin-3, and downregulation of P16 and EGFR proteins was found to predict poor prognosis for lung cancer. Sputum samples, either monolayer or cell block, can be used as an adjunct or alternative to surveillance analysis. And further prospective studies with a more number of samples are necessary for the validation of these marker proteins. Thank you. Next.
We can have the next slide.
Yeah.
Okay. So,
Good evening, all. I am Dr. Sujathan, corresponding author of this paper. This is a part of my lung cancer research program. As you know, the beauty of this work is all those work were done on sputum samples. As you know, sputum cytology, even though it is a similar technique and easier one compared to any other method, it has been neglected because of the paucicellular nature of the sample, nature of the specimen. Dr. Veena could identify a robust technique by which the whole cell content of sputum sample can be used for immunocytochemistry, for protein separation, then DNA separation for PCR and all. So I have done some work on image analysis for malignancy associated changes. As you know, Fourier trichography is very effective for that. And I have done Raman spectroscopy also on sputum samples, which all those works were published once. And now a challenge in lung biology, lung cancer biology is differential diagnosis of lung adenocarcinoma. We have tried immunocytochemistry on sputum samples for the differential diagnosis of lung adenocarcinoma. We have tried this panel, TTF1, NAPSIN-A, and P40, and currently we are trying to develop a multiplex immunohistochemical technique by which these three markers can be tested in a single sputum samples. Similarly, DNA replication licensing protein and galectin-3 has been found to identify malignant cells in sputum samples. And we are trying to develop an alternative technique for identifying DNA replication licensing proteins and GAL3 in sputum samples. Now we shall take the questions.
Thank you, Dr. Veena and Dr. Sujathan, for sharing your valuable work with us. So I have a couple of questions, and this work actually reiterates the fact that cytology specimens, they are kind of useful specimens for doing ancillary studies such as immunocytochemistry, as has been done in this work. So we have a couple of questions. The first question from Dr. Radhika Srinivasan, that EGFR immunocytochemistry, was it correlated with the histological subtype? Have you found it more in adenocarcinoma or squamous or small cell? What was the correlation of EGFR?
We haven't correlated with the subtypes. We have done the survival analysis only. Subtyping we couldn't do with this EGFR.
All right. And this EGFR IHC was total EGFR IHC, not
total. No, yeah.
All right. The second question we have from Dr. Radhika herself, that what was the concordance of sputum smears and cell blocks on immunocytochemistry?
I prefer to have cell block for immunocytochemistry rather than the monolayered smears prepared. We have prepared monolayers using the SurePath LBC technique. Immunocytochemistry was little bit difficult, but we have tried to enhance cell permeability. We have tried sodium deoxycholate treatment. Somehow
as a mucolytic agent.
Yeah.
Okay.
But we prefer to have cell block. That is much better for immunocytochemistry rather than monolayered smear.
Okay. We have one more question from Dr. Nidhi Anand, and she is saying that since squamous cell adenocarcinoma types have a definite difference in survival, do you think clubbing all types into the survival curves would give valid results?
That requires more number of samples to say whether this is satisfactory or not.
Okay. So more number of cases required to validate these things in future studies. Okay. We have another question from Dr. Pinakin Kaushik, that can we use the same sputum sample for NGS, that is next generation sequencing?
Definitely we can use that. The sputum sample, we are using a pooled sample of 5 consecutive days. Definitely the cells can be fished out and DNA can be extracted from those cells. That can be used.
Okay. Yeah, this as I've shown that the scraping can be done from the
smear.
Use the tumor out from those smears. All right. Then I think related to this work, we have these many questions only. There's one more question from Professor Radhika, that how sputum sample was collected.
So as we do in routine cytology lab, we collected early morning early morning samples for 5 consecutive days. And patient was advised to collect samples at home and bring to the cytology lab.
Okay. Yeah, we have these many questions. Thank you very much, Dr. Veena and Dr. Suchathan, for sharing your work with us. Now we have a second speaker, who is Dr. Vani Gupta. She is MD Pathology from Dr. RML Institute of Medical Science. She has done postdoctoral certificate course in oncopathology from the same institute. She's ex-senior resident, Department of Pathology. Dr. Vani, over to you.
Thank you, ma'am. First of all, I would like to thank Journal of Cytology for selecting my paper for this prestigious award. I am here to present my study titled Comparative Study of Cell Block versus Biopsy for Detection of EGFR Mutations and ELF protein rearrangement in Adenocarcinoma Lung. This study was done in 2015, around 2015-16. So now the guidelines for the mutation testing in lung cancer has been changed. It is an old study, and I have done this study at that time only. She is the co-guide. She is the guide of my paper. She has guided me in this study, Professor Nuzhat Hussain. My paper was published in Journal of Cytology in the year 2019 in January issue. So the discovery of molecular markers in non-small cell lung carcinomas has started a new chapter in the diagnosis and treatment of lung carcinoma. The important predictive markers in adenocarcinoma lung are epidermal growth factor receptor, EGFR, and anaplastic lymphoma kinase ELF, against which targeted therapy in the form of tyrosine kinase inhibitors are available. Few words about EGFR. This EGFR is a member of the transmembrane receptor tyrosine kinase superfamily. This mutation is found in about 10 to 23% of adenocarcinoma lung, and this percentage is even more in cases from India. The two most common EGFR mutations are small deletions in exon 19, that is E746, E750, and L858R missense mutation in exon 21. ALK protein, an inversion event on the short arm of chromosome 2 resulting in the fusion of ALK gene with EML4 gene locus is the most common aberration which is present in case of lung cancer, and this mutation is found in about 2 to 7% of lung adenocarcinomas. So preferred methods for detection of EGFR are gene sequencing and PCR, and for detection of ALK is FISH, but these are high-end techniques and these are not available in most laboratories. In comparison, IC is a less costly technique and it is widely available method. So objective of this study was to compare cell block versus biopsy for the detection of these two mutations using immunocytochemistry in adenocarcinoma lung. So this was a tertiary hospital and laboratory-based case series for diagnostic evaluation. Cell blocks were prepared and biopsies were taken from suspected cases of lung carcinomas. So how we prepare the cell blocks? The effusion fluids or the residual material from CT-guided FNAs or transbronchial needle aspirate, these were taken for preparing smears for cytological diagnosis. The residual material was flushed in a 10 ml disposable centrifuge tube having freshly prepared methanol alcohol formalin substitute, which consists of 9 parts of 100% alcohol and 1 part of 40% formaldehyde, and this was centrifuged at 400 RPM for 6 minutes. The pellet was made and it was processed under a short processing schedule, 6 to 8 hours. So next slide. So no additional passes were done to obtain material for cell block, and pertinent clinical details were also documented. Then both biopsies and cell blocks were screened for the presence of non-small cell lung carcinoma, and non-small cell lung carcinoma cases, they were further categorized as squamous or adenocarcinomas using an IHC panel, CK7, TTF, P40, P63. Now the methodology, EGFR mutation testing was done by on cell block samples as well as on the tissue using mutation-specific antibodies, that is E746, A750 deletion-specific mutation antibody and L858R mutation-specific antibody. And the ALK rearrangement was tested using IC on Ventana system using anti-ALK D5F3 clone, and the results were compared for both biopsies and cell blocks. So for EGFR, a score of 3+, that is brown staining with obvious particles, more than 3+ intensity in more than 10% tumor cells, we considered is positive for EGFR IHC. And for ALK interpretation, we considered a case as positive for ALK if there is a presence of strong granular cytoplasmic staining in tumor cells. That is, if any number of tumor cells, it shows a strong granular cytoplasmic staining, we call it a positive ALK case. So it is a flow chart to show that the flow chart of the work. The cell blocks were prepared and they were further categorized as non-small cell lung carcinomas and further as squamous, adenosquamous, further category by using a IHC panel. So then a statistical analysis was done. The diagnostic accuracy, sensitivity and specificity of EGFR and ALK protein expression in cell blocks was compared with the respective biopsy, and we considered a p value of less than 0.05 to be significant. So now results and discussion. The study, it includes 57 cell blocks, among which 55 were prepared from aspirates from interthoracic mass and 2 were prepared from bulk fluid. Out of these 36 cell blocks, 57 cell blocks, 36 came to be malignant and 8 were non-malignant. 13 cell blocks were inadequate. These cell blocks were given a diagnosis of malignancy on histology. The main reason for inadequacy was if there were scant neoplastic cells, and other reasons were hemorrhagic background, or when cell block, it contains only normal cells or less number of cells, less number of tumor cells. So out of these 36 malignant cases, 5 cases were of small cell carcinoma, 30 were of non-small cell carcinomas, and 1 case was of Ewing sarcoma. Out of these cases of NSCLC, 18 cases were diagnosed as adenocarcinomas. 1 was of adenocarcinoma with neuroendocrine differentiation. 1 was adenosquamous carcinoma. 2 were undifferentiated carcinomas, and 8 cases were of squamous cell carcinomas. The age of the patient ranged from 27 to 75 years, with 7 females and 15 males. 21 cell blocks were prepared from CT-guided FNA materials, and 1 cell block was prepared from bulk fluid. So breathlessness was the most common presenting complaints of the patient, and it was followed by pain in chest and hemoptysis. Among these 22 cases, these were tested for mutant EGFR protein expression. The 2 cases were positive for EGFR mutation, and both the cases, they showed this exon 19 deletions, and the results were similar on biopsy and cell blocks in terms of positivity and negativity. And I also like to emphasize here this current study was carried out in 2015-16, and we only attempted to compare ISC in cytological and histological samples. So now the EGFR detection by monoclonal specific antibodies, it is not approved by the NCCN guidelines. So it is one of the case. Figure A and B show the biopsies of a case of adenocarcinoma lung. Figure C shows it is positive for CK7, and D, it was positive for TTF1. So it was diagnosed as a case of adenocarcinoma. The figure E and F, they show that this case was negative for EGFR mutation by ISC. G figure shows that this case was also negative for ALK protein expression. I and H are the cell blocks slides for the same case. And on cell block also, this case was found to be negative for EGFR protein antibody as shown by J and K figure, and I figure showing that cell block is also negative for ALK antibody expression. So the results were similar in biopsy and on cell block. So it is another case, A and B figure showing the biopsy of the case. It was positive for CK7 as the figure C shows, and D shows the TTF1 positivity. So it is a case of adenocarcinoma. It was further subjected to EGFR protein expression ISC testing. So it came out to be positive for that exon 19 deletion, that is A746, A750 ISC antibody. And G and H are the cell block for the same case. And on the cell block, it came out to be positive for EGFR. So in this case also, the positive, both the biopsies and the cell blocks are positive for EGFR mutation. So ISC as a method for testing EGFR mutation expression, it is a cost-effective, fast technique. However, it is not approved method of EGFR expression as per new guidelines and should not be used as of today in clinical reporting. The approved methods for detection of EGFR mutation are direct sequencing and real-time PCR, droplet digital PCR. But these are expensive methods. They also need high expertise and requires at least 20% of all DNA sample. These molecular techniques can also be affected by degraded and poor nucleic acid quality obtained from material. In comparison, IHC is limited by being able to detect only the 2 most common mutations of EGFR, and if negative, the molecular markers are required to check further mutations. Next. Among 22 cases which were tested for ALK IHC, only 1 case was positive on cell block, and the results were concordant with the biopsy results for positive and all negative cases. The detection of cytological samples matched with histology. At the time of the study, FISH was the gold standard for detecting ALK protein mutation. However, as of today, IHC on Ventana platform is also used as a standard practice. FISH is a costlier technique than IHC. Moreover, its interpretation also needs expertise, which is not a problem with IHC. So this was the case which came out to be positive for ALK protein expression. A and C figure shows the biopsy samples of the same case, and the next slide showing that the biopsy was positive for ALK IHC. And below is the cell block for the same case, showing positive ALK expression. Cell blocks carry a definite advantage over conventional smears with reference to IHC, since they go through histological process and can provide multiple sections for IHC and molecular studies. And the method for preparation cell blocks are also simple, and they can be readily adapted in routine hospital laboratory, since in the lung biopsy, tissue is always an issue, which many times we get only a small biopsy sample or fragmented biopsy sample. Moreover, in many setups, the guided FNA procedures, these are not performed by pathologists. So spreading and drying effects are also an issue for interpretation in the direct smears. It is a chart showing the complete analysis of the patients, these 22 cases, which I analyzed. So 2 cases were positive for EGFR antibody and 1 case was positive for ALK. There are certain limitations of this study. First is a limited number of cases. So as we see that although we prepared 57 cell blocks, but only 22 cases, these were diagnosed as adenocarcinomas. So the sample size was less. Also, the study used naive pre-treatment samples for analysis, and no follow-ups for detection of post-treatment or chemotherapy changes have been recorded. And the EGFR IHC has currently not been accepted as a standard technique, as it does not cover the entire range of mutations. So to conclude, I would like to say that molecular testing for EGFR and ALK is an essential part of the non-small cell lung carcinoma diagnostic workup, as targeted therapies are available against these predictive markers. The current NCCN guidelines 2020 advise that we should done EGFR mutation testing, ALK testing, ROS1, BRAF, MET exon testing, and RET and PD-L1 testing for these adenocarcinomas lung. And cell blocks are potentially accepted alternatives for detection of these markers by IHC and molecular methods wherever tissue sample is not available or is inadequate. Thank you.
Thank you, Dr. Vani, for your presentation. So we will take questions after the third and final presentation of today, as both of these 2 papers are somewhat related and talk about predictive biomarker testing in cytology specimens. So for the final presentation, I would like to invite Dr. Soumya Shukla. Next slide. Dr. Soumya Shukla is a professor in Dr. RML Hospital, Lucknow. From the same institute, she will present here her work. Dr. Soumya.
Thank you, ma'am. Very good evening to all. I would like to thank the Indian Academy of Cytology for this opportunity. We at the Molecular Pathology Division of Ram Manohar Lohia Institute of Medical Sciences, Lucknow, are testing for multiple predictive and prognostic markers in lung. This current study is a part of the multiple research projects which we have done in lung. The study is titled Cytomorphological Features of Anaplastic Lymphoma Kinase Gene Rearrangement in Lung Adenocarcinoma. I'm obliged that this paper has been selected as a part of the Jewel 50 series in the Best of the JOC publications. The co-authors for this paper include Professor Nusrat Hussain, Dr. Anurag Gupta, and Dr. Nidhi Anand. The anaplastic lymphoma kinase gene is a predictive and prognostic marker in lung adenocarcinoma, identified in about 3 to 5% of all cases. This novel gene rearrangement was first identified by Hirayu Kumano et al., and the presence of this rearrangement leads to the production of a chimeric protein, which is responsible for inhibition of apoptosis and promotion of cell proliferation in the tumor cells. There are certain clinical and pathological features that have been specifically documented in cases that harbor this translocation. It's more frequent in non-smokers and is associated with hepatic and brain metastasis. Pleural and pericardial effusions are more common in cases that harbor this rearrangement. Crizotinib, the oral selective drug, has been now approved for treatment of cases that harbor this rearrangement. The current study was taken with the objectives to analyze specific cytomorphological features of lung adenocarcinoma that harbored the anaplastic lymphoma kinase gene rearrangement, and to compare the morphological features of ALK positive cases with the mutation negative cases. The current study was a tertiary care hospital-based retrospective case series wherein 40 cases of lung adenocarcinoma was included. The cases were diagnosed on histopathology with or without the aid of IHC. A basic panel of IHC, which included Napsin-A, TTF, and P40, was applied to all the cases. The ALK testing was performed on the corresponding biopsy sample of all of the cases. The ALK testing was done using the D5F3 clone from the Ventana Medical Systems. The testing was done as per the approved FDA guidelines on the Ventana Benchmark XT system, using the D5F3 clone, the OptiView DAB, and the OptiView amplification kit. We ensured that we ran a positive and a negative control with each batch, and we assessed cytoplasmic membranous staining. The assessment was done as cytoplasmic and membranous, as I have already mentioned. The next slide, please. Following which, we retrieved the cytology smears in all the 40 cases. Now, amongst these 40 cases, 15 cases were positive for ALK gene rearrangement, while 25 cases were negative. The air-dried and wet-fixed slides were retrieved, and we analyzed the cytomorphological features under 4 categories, which included cellular rearrangement or pattern, wherein the papillary, acinar, sheet, cluster, or singly scattered cellular pattern was assessed. We assessed the nuclear features, which included nuclear pleomorphism or the presence absence of nucleoli. The presence of mucinous features or signet-ring morphology was assessed, and the background of the tumor cells was assessed as in the presence of necrosis. The statistical analysis was performed using the SPSS analysis software, and p-values of less than 0.05 were considered as statistically significant. The study group included 40 cases. As I've already mentioned in the materials and methods, ALK testing was performed on the histology slide. Here in figure 1, we can identify that about more than 90% of tumor cells demonstrate strong granular cytoplasmic staining, whereas in figure 2, we can see a case which is negative for the ALK gene rearrangement. Now, as I mentioned in the methodology, we analyzed the cytomorphology under 4 categories: the cellular pattern and arrangement. So majority of cases had a mixed pattern of cellular arrangement, which implies that we identified more than one feature in the cytomorphological features. The ALK positive group documented the presence of a sheet-like arrangement in majority of cases, which was 93.3%, followed by clusters and singly scattered cells, whereas the papillary pattern was the least common pattern. In the ALK negative group, the presence of clusters was the most dominant pattern. So a comparison between the ALK negative and the ALK positive group highlighted that the presence of sheets and singly scattered cells was statistically significant in the ALK positive group when compared to the ALK negative group, with p-values of 0.38 and 0.44% respectively. This is a photomicrograph showing the presence of a cluster in figure 3, whereas figure 4 highlights the presence of a sheet-like pattern of the tumor cells. In figure 5, the red arrow points towards the presence of the acinar arrangement of the tumor cells, whereas in figure 6, we can see singly scattered atypical tumor cells. The next characteristic analyzed was the presence of nuclear features. Moderate to severe nuclear pleomorphism was identified in 80% of ALK positive cases and 72% of ALK negative cases, whereas 80% of ALK positive cases documented nucleolar prominence. However, none of these two parameters were statistically significant when compared to the mutation negative group. So this is a photomicrograph wherein we can see a sheet-like pattern of arrangement of cells with moderate to severe nuclear pleomorphism. The presence of mucinous or signature morphology was identified in 73.33% of ALK positive cases and 24% of the ALK negative cases. This was the most striking statistically significant criteria with a p-value of 0.002. Herein, we can see that there is a loose cohesive cluster of tumor cells in figure 8, and in the background, we can identify the presence of extracellular mucin, wherein in figure 9, the red arrow points towards a signaturing cell with intracytoplasmic mucin. The presence of necrosis in the background was documented in 80% cases of which were ALK positive and 28% of the ALK negative group. And this finding was also statistically significant when compared to the ALK negative group with a p-value of 0.001. So this is a figure wherein we can see a sheet-like pattern of tumor cells and presence of background necrosis. So this table represents the statistical significance between the ALK positive and the ALK negative group with the two major criteria, that is the presence of mucin and a necrotic background. This is a graphical representation wherein we can see the most striking features which we identified in the ALK positive group, which included the presence of sheets clusters along with moderate to severe nuclear pleomorphism, presence of mucin, either intracytoplasmic or extracytoplasmic, and a necrotic background. So there are a few studies which have been published in literature wherein the cytomorphological features of ALK rearranged lung adenocarcinomas have been evaluated. Cytological specimens represent a significant proportion of samples which are now being submitted for the diagnosis of lung adenocarcinomas. Additionally, now cytological samples are widely being used for molecular testing, especially in cases where disease presentation is at an advanced stage or obtaining a biopsy is difficult. So in the current study, as I've already mentioned, the most common cellular pattern of arrangement was a sheet-like pattern, which was statistically significant. And this was in concordance to the study conducted by Ha et al., where he documented a presence of sheet-like pattern in about 93% of ALK positive cases. Whereas the ALK negative cases in the current study harbored the presence of clusters. In the study, which was conducted by Lee et al., the most common pattern in the ALK positive group was an acinar or a glandular pattern, though in the current study, we documented it on only about 46% of cases. A detailed examination of the background revealed the presence of necrosis in about 80% of cases, which is in concordance to the study conducted by Lee et al., wherein the authors documented the presence of necrosis in about 67% of ALK positive cases. ALK positive cases displayed moderate to severe nuclear pleomorphism along with nucleolar prominence in 80% of cases. This finding, though, was not statistically significant, but in a study conducted by Lee et al., the authors stated that cases that harbored the epidermal growth factor receptor mutations, those mutations which are the commonest in adenocarcinoma lung, are generally well differentiated with a low-grade nuclear morphology. Hence, the presence of high nuclear grade in a tumor may indicate an EGFR negative profile and may favor the presence of ALK rearrangement. The most salient feature in the ALK positive cases was the presence of mucinous or signaturing morphology, and this was statistically significant when compared to the ALK negative group. The presence of mucinous features is the single most significant cytomorphological feature. This characteristic can serve as the most vital criteria for the identification of cases that have the likely probability to harbor the ALK rearrangement. Identification of subtle cytomorphological features that support the probability of ALK rearrangement may have diagnostic implications. Biopsy submitted for histopathological examination is at times insufficient for molecular testing. Procedure to obtain a lung biopsy is cumbersome and difficult. Hence, an attempt to identify the morphological features supportive of ALK rearrangement may aid in more judicious use of the biopsy tissue. So I would like to conclude that in cases with ALK phenotype, the most common pattern of arrangement is the sheet-like pattern associated with presence of singly dispersed cells or the presence of mucin. These tumors generally have moderate to severe nucleomorphism with presence of necrosis in the background. And identification of these subtle cytomorphological features and patterns may aid in triaging the cases that have the probability of the ALK phenotype, which further has predictive and prognostic implications. These are some of my references. This is the faculty at Dr. Ram Manohar Lohia Institute of Medical Sciences, and below is the photograph of the research team, which actually looks into molecular testing. We are currently testing for ALK-ROS and EGFR at the Molecular Pathology Division of RML. And now I would like to introduce Professor Nusrat Hussain. She is the Dean, Professor and Head Department of Pathology at RML. She's also served as the Director. She has multiple research projects on multiple solid malignancies, and she has more than 250 publications. She's been our mentor and always ensures that we do good research and publish our research. And she's also the corresponding author of this paper. Thank you.
Thank you very much, Soumya, for sharing your valuable piece of work. And thank you, Professor Nusrat Hussain, for mentoring these two papers. And both these papers actually emphasize the fact that cytology specimens are valuable resources and they can be used for diagnostic testing as well as for predictive biomarker testing. And these are a very useful resource. So I have a couple of questions. The first question is from Dr. Nidhi Anand. She's asking, I think, in reference to Dr. Vani's paper, that had she tried EGFR and ALK-IHC on cytology of any metastatic site from lung cancer. So Dr. Vani can take this question.
No, ma'am. In this study, we only compared the results of biopsies from the lung adenocarcinomas cases, not from the metastatic sites.
Okay, so from the primary site only you evaluated.
Yes, ma'am.
Okay, thank you. Next question is from Dr. Varun Vijay. He's asking, I think Dr. Soumya, that have you done morphology analysis of ALK positive cases in histopathology? And if so, what is your experience?
Yes, we have done that. We've done it in about 100 cases wherein we did try to compare the histomorphology of ALK positive versus the ALK negative cases. In the histology, we found two criteria which was quite significant. One was the presence of mucin, either intracytoplasmic or extracytoplasmic. And additionally, we found that the ALK positive cases had severe nucleomorphism with presence of necrosis. In my histology part, I did not find any pattern which specifically pointed towards an ALK positive group, which is a little different from literature wherein people have documented that at times ALK positive cases have a more acinar arrangement. Though in my study, I was not able to document that because majority of my tumors are of a higher grade.
Yeah. So yeah, similar to the literature, you have found mucinous and signaturing cell cytology in your cases. And in histology, usually it's solid pattern, which
Yes.
is ALK rearrangement. But yeah, but you have not got that. That's fine. And there is a question by Dr. Radhika to Dr. Nusrat Hussain. She has already answered that elk fish on cytology smears. Any experience?
Yeah, so we did do the fish on the direct cytology smears. And then, of course, the limitation is that you need to have at least 50 cells to count. And you
Yes,
should
ma'am.
get it. But, you know, actually the signals are pretty good in the direct fish.
Yes, ma'am. And we avoid actually nuclear truncation artifact, which we get in.
Exactly. So in fact, it's a kind of easier to do than in the histology.
Yes, ma'am. Yes, ma'am. Monolayer preparations are very good. All right. So yeah, I think we are done with the questions. So interesting discussion on lung cancer this day. And in summary, I would say that all these papers state that cytology specimens are as good as histology specimens. So do not discard anything. You can use all cytology specimens, not only for diagnosis, but also for predictive biomarker testing. So with that, I would hand over this session to Dr. Prabal Dev for his final concluding remarks.
Thank you, everyone. Before we conclude, I would like to thank Dr. Dipali, my co-chair, and all the authors of the 3 award papers to take us through the excellent work that have been done that highlighted the need for molecular and ancillary workup in domain of pulmonary tumors using cytopathology samples. I also take this opportunity to thank all our esteemed participants in this evening's deliberation, and special thanks to Professor Radhika Srinivasan and Dr. Sandeep Mathur for all their support in taking us through this wonderful online webinar. Prior to signing off, would request all of you, all the esteemed members, to kindly join us in the next webinar, which would be a continuum of this Jewel 50 series. Thank you and good night to all of you. Have a great and safe weekend. Bye.